everybody, and thank you so much for joining us tonight for our PiezoWave Open Forum. I am very excited to have Dr. Wendy Herlihy here tonight. She runs now a standalone rehab in Colorado, started as a mobile rehab, has progressed to a standalone rehab, um, and has done some amazing things with the PiezoWave. And she also has a great technician named Deana. Their communication and time is just so amazing and so special. So I'm glad to introduce you to with Dr. Wendy, and I'm going to turn it over to her. She's going to give us a little background about a few of her PiezoWave cases, and then how she got her technician up and running to be so proficient with our Shockwave. I do think we all have to keep in mind that before I turn over to Dr. Wendy, that the PiezoWave is as good as its operator. So training whoever is using it is one of the most important parts, and I'm excited to see Wendy's input on this. So there you go, Dr. Wendy. Take it away. Thank you.
All right. Thanks everybody for coming and the nice intro, Cindy. Okay, so I'm just going to start with a couple of cases that I think are fun. I think cases are really where the rubber meets the road in terms of our interest. So that's why I have two. I mean, I could talk to you for a whole hour about interesting cases, but I just picked out two. And this first one, Cindy's the one I've been wanting to share with you for a long time, but just haven't gotten around to doing it. So this case, Desi, he really highlights the efficacy of the Shockwave. And so that's one of the reasons I like it. So Desi came to me. He was a 10-year-old Border Collie, very, very active dog. He's a retired agility competitor, but still competing. And back in 2020, when he came to me, he was Joni, his mom, was just seeing some differences, knocking bars during his performance, and then not really able to jump into the car with ease. From a standstill, he had to take a running start. So she came to me and I diagnosed him with lumbosacral disease. I wrote the word suspected in front of that because we did not get any imaging. I felt like my exam was fairly straightforward and he was very communicative. So I felt really confident in that. So we ended up not doing any imaging. And I treated him with acupuncture and manual therapy very successfully for a couple of years. So that's kind of his background. And a couple of years after we started, he came to me acutely lame, total different body part, right? Forelimb, after playing a hard game of fetch. And so when he came to me, I remember it was Memorial Day and Joni's really on it in terms of being an owner. So I saw him just a couple of days after the injury. It was acute and he was non-weight bearing for a few days. When I saw him, he was weight bearing just a little bit. And I could appreciate what I call slam dunk pain on supraspinatus and biceps. He was not easy to tease, or not difficult to tease apart. He was pretty straightforward in terms of getting diagnosis based just on palpation alone. I had talked to Joni a little bit about doing musculoskeletal ultrasound to confirm. I discouraged her a little bit in that his exam was so straightforward. I felt really confident in my diagnosis. And I said, I think at this point, I'd rather put your dollars towards treatment unless we're not getting as the efficacy we want, then maybe we go back and do imaging. So we just moved forward without any imaging. And our plan was as follows here on the slide. We're going to do 5 sessions. I've had my Shockwave, 5 years now? And I've really come to this place where if I'm trying to solve a problem, I set owners up for the expectation of 5 sessions. If I have a dog in maintenance who's coming in and they're already doing well, I'm trying to maintain joint health is a really common way I do that for arthritis, then I do a series of 3. If I have a dog whose owner is financially taxed and they can only do 3 and we're trying to solve a problem, I'll certainly do that. But I much prefer 5. So that's what I set owners up for. We really wanted to get Desi kind of back in action with his agility for fun those days. And so we were pretty aggressive. So 5 Shockwave sessions, acupuncture, every week for the foreseeable future. I rented an at-home 3B laser to Joni. I always do manual therapy alongside acupuncture. Those two kind of go together for me. I have a very, very specific therapeutic exercise plan for tendinopathies, not just in the shoulder, but other body parts. I did actually use an NSAID in Desi, which NSAIDs typically don't work well in tendinopathies, but just because of the nature of his injury was so acute and he was so lame. So we just did a 7-day course and it helped a little, but not a ton. So that's not actually that surprising. Okay, so there's my plan. But what actually happened was he had 3 shockwave sessions, 3 acupuncture sessions. He went from grade 5 lameness to grade 1, which in my opinion is a marked improvement over 3 weeks when you have such a severe acute injury. And he only had mild pain on palpation. So we were like moving in a wonderful direction, really happy with how things were going. Alas, he chases a squirrel in the backyard. He doesn't go all the way back to grade 5 lameness, but he gets much worse. He goes back to grade 3. So we quote started over in our timeline, which is a bummer. So we kind of started over with our period of rest before diving into our exercises and trying to, in terms of those 5 shockwave treatments, we started over. So here we go, 5 additional shockwave treatments. Because this is getting more longer term, we had to go out to every other week acupuncture manual work just for cost. I did the NSAID again, but just for 7 days. It gave us a mediocre response to that. And we restarted our exercise plan. So when we go back to day 0, it means I like to rest these dogs for 30 days, really let the tissue rest. And if you guys ever have questions about that, I'm happy to answer that, but let's stay kind of focused on the shockwave piece. So we go another 3 weeks, he goes back to his grade 1 lameness. And at this point, it's only intermittent and it's only at a trot. Can we see just a very slightest head bob? And it's not all the time, it's just intermittent. I was very pleased with this in terms of the progress we were making in the timeline. Desi's mom, Joni, is very particular, I'll say. I really like Joni a lot. She's very particular and detail oriented. And she says, we're not resolved. And I just want to make sure that we're doing the right thing. I want to go get a musculoskeletal ultrasound. And I said, awesome. This is a little bit backwards of how we typically do things, right? We typically do imaging and then we treat what we find on our images as it matches with our physical exam, right? But this was an opportunity for me to say, what does the shockwave look like after 6 weeks of treatment? Or not the shockwave, what does the musculoskeletal ultrasound look like after 6 weeks of treatment? And how does that reflect on like how successful our treatments have been? So it was an educational moment for me. And I was really excited to find out, well, A, were we barking up the right tree, which we were, and B, how bad was it? And how much is the shockwave and our acupuncture manual helping? So that's why I love this case for you guys, Cindy, because it really highlights the efficacy of shockwave in this particular disease process. So I love the quote of the ultrasonographer, who's a good friend of mine. She writes to us, basically the biceps tendon is gone. There is no tendon left. All we have is a sheath that is filled with effusion. And we have a lot of chronicity here, right? Like the bicipital groove is very irregular. We do have some supraspinatus involvement as we typically do, but it is mild. And Dr. Worth, who did this ultrasound for us, is a good friend of mine, like I said, and I'm going to quote her here. She says, I've been doing this work for 20 years and I've never seen a bicep this bad. It's the worst one she's ever seen in 20 years. I was like, wow, okay, holy cow. And what was interesting is that the owner of this dog was like, oh my God, this is like the worst thing she's ever seen. This is crazy. My interpretation of that information is like, oh my God, this is the worst bicep this ultrasonographer's ever seen. We've done 6 shockwave sessions and we're at an intermittent grade 1 lameness only at a trot. Like that's amazing. And the shockwave, I will say, was the core of our treatment. So I'm not paid to say any of this, you guys, just so you know, like this is just a really nice case highlighting therapy. So I was pretty tickled by all this, right? because he wasn't totally healed, we did add a few things. We did some stem cells and PRP into the joint, but this was after we had already achieved an intermittent grade 1 lameness in a trot. And mind you, that's just 6 weeks after onset of injury. And as you guys know, an injury like this takes months to get back to sport. So we're like just at the beginning. We did a bunch more Shockwave sessions, not a bunch. We did a total of 10 over 4 months. I don't often do 10 Shockwave sessions. That's a lot. I sometimes will get up when I have like a pesky medically managed cruciate. I'll sometimes get up into the 6 or 7 sessions. But Desi, we did a lot more. So just to be transparent with that. Oh, and I wanted to show you guys. Here he is. This is a video of him. He's 13 now, so this is a 13-year-old Desi. After all that.
Pretty good. Happy.
Yes. And moving beautifully. Yeah. So, do you guys have any questions about Desi or comments about that case?
I do always, you know me.
Yeah, hit me.
So I mean, I assume as he, returned to a comfortable level, was it without more diagnostic ultrasound? Do you think that tendon ever actually got a good fiber pattern, or he just recovered from pain? Like, what is your thought on that?
What I think probably happened is, and it would be really interesting to do an ultrasound now, after he's like fully healed. What does the tissue look like inside? Okay, my educated guess is that the fibers are still totally ruptured, and that there's been some probably fibrosis where like the tissue rips and then it recoils back. You know what I mean? There's probably been some
Mhm.
fibrosis and adhesion inside the sheath in those places, but we're no longer having that huge fluid pocketing and inflammation and all that tissue. I think partly is we have fibrosis and adhesion, but not too much. Because if we still had a lot, he'd still be painful. I'll tell you
Exactly.
now, yeah, I'll tell you now that he has loss of extensibility of the biceps. It's
Okay.
mild, but I can appreciate that. And so I bet that's what that adhesion slash fibrosis, that's how it's presenting. It's not clinically significant any longer in terms of like not causing a lameness or head bob. That all resolved.
Amazing. Great. Any other questions about Desi? Nobody's
All
jumping
right.
up and down.
Yep.
And the stem cells were put in the joint, correct?
Correct. Yep. Stem cells and PRP were put in the joint.
Interesting. Cool.
Mm-hmm. Okay, this is a totally different kind of case. This is Peach's Delight. That's actually her name. I met her, she was 9 months old, a little terrier, Boston Frenchie Cross. I knew these owners for a bunch of years before this dog. I worked on other Frenchies of theirs, and they came to me because they were noticing an intermittent left hind limb lameness, but it was quite severe. It was grade 5, and most commonly were after a period of exercise, rest, and then getting up from rest. On exam, I found bilateral hip laxity. It was very difficult to elicit. It took me a while to find it. And when they gave me her history, I was convinced she probably had MPLs, given her breed and what the story they told me, how it was like off on like a light switch. Um, I could not get her patellas out of the groove to save my life. I tried for a long time. And then I was like, I got to look elsewhere. Like, this is something different. And what was interesting is I could only appreciate the laxity in standing. In sideline, I could not get it. And so that was a nice lesson for me. And that still is the same in this dog. I've worked with her probably a year and a half now. It only presents in standing. So anyway, she has bilateral hip laxity. I also found mild lumbosacral pain and some severe loss of tail extension, like with a hard end feel, like there's something structurally abnormal in her sacrum going on. Because she was so young, even though I knew her lameness because I really thought it was the hip laxity because that was so much more significant than her LS pain, which was just very mild. I did order the diagnostics, the RADs, because she's so young and she's a Frenchie. And I just wanted to know, like, what are we dealing with orthopedically? Interestingly, we found she has 8 lumbar vertebral bodies. So that's probably why her sacrum and her tail base are not normal. Um, and the radiologist did see slight subluxation, but noted it's an expected finding for this breed. For this particular individual, it's definitely showing up as discomfort. So it was clinically significant for her. All right. So Peaches, because I was trying to solve a problem, we did 5 Shockwave sessions every week. I do offer Shockwave every 1 to 2 weeks to my clients, but I prefer weekly. I just anecdotally feel like I get a little bit more bang for my buck if I can keep it a little tighter. I did all the other things too. On an every other week basis, we did all what I call our traditional rehab modalities that are listed there. I wanted to give you some Shockwave details for her, if that's helpful for you. And then we'll talk about like and my technician did all the Shockwave. I didn't do it. We chose a linear head so we could scan around that hip joint. I really love the linear head for hips. I think you could argue you could use a focal head for this dog because of her size. So it's really personal preference. I really like to do a layered approach. So you see we're using 2 different pads, and we did 2,000 pulses each pad for a total of 4,000 pulses over each joint. I'll just say that the elephant in the room is that's a big dose, and I know that, and I'm a big doser. And you should do whatever you're comfortable with. The reason I do the big dose, we could talk about more of this in training, is that I believe that if I give 4,000 actual pulses into a joint, my goal is that 3/4 of that are actual treatment pulses. Because the reality is the dog is moving, the gel is slippery. I look away for a moment, the things turn. And so I know that some percentage of my pulses are what I call non-therapeutic. And so that's why I like to do such a big dose. And what I've also found is I'm not making dogs sore. Um, and so that's why I feel like I'm gaining more than I'm losing with that. I don't really feel like I'm losing anything. We also treated LS because we're right there. Uh, and why not? And so one kind of thing of note I wrote here, intensity of 13 or lower using that head. So what I've found is if I overdo the intensity over the LS region of the body, and this is the only area of the body I found this in, I will make a dog sore, and not just sore for like a day, but maybe sore for a week. And I just speak from experience. I've done that twice. And so I have found that if on the focal head I stick to 4 or below, I get really good efficacy without soreness. And if you cross-check the power over to the linear head, that gives us 13 or below on our machine. So that's my little thing that is just my comfort level. When we do LS region in my clinic, we call it a region. I always treat obviously LS. I like to go one segment forward because I find there's often pathology there too. I like to come up and around the sacroiliac joints, and I like to drop back and do S1 too, as well. So when we do an LS in a dog, we do kind of a whole region, if that makes sense. So we ended up kicking Peaches into a maintenance plan, and I wanted to mention this because it was interesting. We started out the first year doing our series. She was doing really well. I guess I should tell you the outcome of this. Her lameness is completely resolved. We never saw it again, and she's extremely strong. Like at one point, this is a funny story. I'll throw my technician Deana under the bus for a second, but one day Deana comes in, she's shockwaving Peaches, and she's like, "You got to come in here. I don't know what this muscle is. Like it feels different. Like what is this muscle on this dog?" And I laughed. I was like, "Deana, that is a ginormous gluteal. It's just ginormous. Like it's like abnormally large because these folks don't walk their dogs. They do therapeutic exercises at home every day. That's their jam." And so I just like had to laugh. I was like, "Oh my gosh." It's like abnormal, but it's actually amazing. So we kicked Peaches into her maintenance plan, and we decided we were going to do a series of 3 Shockwave sessions over all those areas quarterly. And that went great for a year. And we continued with our every other week rehab. And after that year, I said, let's kick her into every 6 months. Like she's done so great. I think that will work for us. And I was absolutely wrong about that. That did not work for us. And she started having some intermittent lameness again. And we tuned her right back up with a series of 3 Shockwave. We started to see that. And I said, you know what? I think we're just going to hold her at quarterly. And we've had 2 quarterly sessions that she's maintaining resolution of clinical signs. So that was interesting. I tried to push her out because she was so young. And I thought, we probably don't need it. But I was wrong about it. She does need it.
Yeah,
Do you guys
the
have?
maintenance plan, I think the maintenance plan is so dependent on the dog and the body part.
Mm-hmm.
I treat at my home, I don't know how I ended up doing this, but a black lab which had horrible shoulder tendinopathies, but then ultimately the lameness was from elbow arthritis once we got all the shoulders healed up. And if she goes longer than 6 weeks, if I treat her once every 5 to 6 weeks, she's golden. If she lets her go longer, no good, you know, just she just gets lame. And that's OA. So that's interesting that yours is so young, you know, and still needing the maintenance, but it happens for
Yeah.
sure,
And I mean, and honestly, she's not on a single pharmaceutical.
which
And
is
which is like fantastic, right? She's like a year old. So the owners are like happy to pay for Shockwave. She's not on any drugs. Like we love it. So, I think it's a total win for her.
amazing.
All right. Yeah, all right. Let's see. Okay,
Anybody
so
else have questions, comments about Peaches just before we move on? And do you think I do? I'm always sorry, but do you think that pain was mostly the hip joint pain or all the surrounding structures for her?
I think for her age, she didn't have time to develop arthritis yet. So I think it's all the soft tissue structures around the joint. So the joint capsule, the labrum, the round ligament that is either torn or stretched. And then
Mhm.
all the tendons of the muscles that are going over that joint that are getting inappropriately stretched.
Yeah, I agree. I was just curious because I think with the hip especially, that's a joint where the surrounding structures and muscles have so much to play in it,
Hmm.
hold it together, right? So,
Yeah. Yeah. And she didn't have any radiographic signs of arthritis at that age. And I'd be surprised if it had time to develop.
yep,
So
yep.
I feel like we have to be treating soft tissues.
Mhm.
Okay, let's dive in. Training your technician. So I thought we could go through when I put this together, I was like, okay, like how did I actually train my technician who has turned out to be excellent? And these are sort of the 4 things I wanted to kind of discuss with you guys. And we'll go through, there'll be a slide on each one. So and these are sort of goals that I had for my technician. I wanted her to be able to discuss the mechanism of action with our clients, answer questions, make recommendation of Shockwave. So if she's working with someone through like therapeutic exercise or massage, she knows when to say, hey, I think Shockwave would be a good modality for your dog. And then also just setting owners up for clear expectations during the visit and then after. So let's talk about all those. Okay, so for Deana and I, when I trained her, we had like 6 months together, and some of it was one-on-one, but it was a little bit didactic. So me like talking to her and then her answering or asking questions. And so this was sort of like a didactic piece. Um, and what I wrote here on the slide is like what I really wanted her to have around as like walking around knowledge. So something that she can just, when owners ask, like, how does this work? What is this? She can say some form of what's on the slide. I want her to understand mechanotransduction and be able to describe it to an owner in a way that's like plain English and not doctor speak. And then what, like, how does that help us clinically? What tissues are actually healing? What is happening in the body? And I wanted her, this is not a full list, but this is like, here's my goal of like what you can say out loud without refreshing yourself. Um, and so when I taught her all this, I taught her more depth, but it was clear that like, hey, this is what I want you to be able to talk about: the cartilage healing, tendon, ligament, muscle, blood vessel development, stem cell recruitment, and then osteoblasts and how they're related to both bone healing and arthritis. And so she might not talk to a client about all these things. She might say, hey, in your case, we're treating your dog for arthritis. So let's talk about stimulating the osteoblasts underneath that hyaline cartilage that will maintain cartilage health over the life of your dog. And we might not be talking about tendon and ligament or muscle healing in that particular owner. Some owners don't really want the detail. And so I have this I want her to always be able to say like Shockwave is stimulating the body's own healing mechanisms. We occasionally get owners that are like, I don't really care about the science, like give me the one-liner. And so like I wanted to give her the words to be able to say this stuff confidently. All right. And I'm sure like if you're training someone, you have all the things you think are important. This was just my list in terms of being able to describe and teach what Shockwave does. Answering client questions. And I think in rehab, we get clients to do research online. And so there's a lot of confusion about the different kinds of Shockwave and does it require sedation? And I don't want to do Shockwave because I'm going to have to sedate my 15-year-old and all this stuff. And so I wanted Deana to be able to explain why someone might have some misinformation, what type of unit we have, and why we don't need sedation, and the difference between like a piezo and a hydroelectric, not scientifically, but like how it applies in clinic. It's not loud, it's not scary, it's not painful, and there's no sedation required. If I had to like rattle off the things that I wanted to make sure we conveyed to our owners when we're trying to offer the service to them. And then I sort of joke, I say this to owners when I say, hey, I think your dog's a good candidate for Shockwave. I usually say, this is not shock therapy. This is a high powered ultrasound. And I just like get that out of the way. And I wish you call it Shockwave, to be honest with you. Because people get confused and they're like, oh my God, I don't want to shock my dog. I'm like, no, it's ultrasound therapy. It's just a funny name. So anyway, and so I think when I thought about teaching Deana, I wanted her to be in the room feeling confident because she's not in the room with me. She runs her own appointments. She's by herself. So she needs to feel confident. She understands the modality. She understands the machine. She can answer a lot of the common questions we get when owners do research online. Okay, number 3, making the recommendation of Shockwave. So I wanted Deana to understand, like I said, she's working with a dog in a different capacity to be able to say, you know what, we keep having, I don't know, I'm going to make this up, breakthrough pain on your elbow arthritis dog. I think it's time that we do some ongoing Shockwave for this patient. Let me explain to you how it works and why it will work for your patient. So kind of the indications, I wanted her to have that as walking around knowledge, not every little thing, but the biggies. And so for me, the biggies is what I listed here. We do it a lot for OA, joint disease that isn't OA. So that could be, that could be like the luxating hips that we did on Peaches, right? That could be any number of things. Any kind of soft tissue injury, we know Shockwave really shines there. Fracture healing, sometimes we forget about, but it's actually a great modality for that. And I do like a fracture healing section of my Shockwave when I'm doing post-op TPLOs. And so we do our TPLOs a little different. We'll come in from the lateral side, so we're not trying to go through that bone plate. So we'll talk to owners about if we're doing Shockwave post TPLO, how we're sort of, I say, killing 3 birds with 1 stone, right? We're doing a preemptive OA treatment to protect cartilage. We're helping with that osteotomy site, and we're helping with soft tissue healing after a traumatic surgery. And then, of course, wound healing and any kind of myofascial dysfunction, like a tendinopathy, psoas strain, that kind of thing. I think we should also, our technicians who are delivering the treatment should know the difference between why we do more sessions during an initial Shockwave series versus ongoing. We'll maybe do less. And we do some ongoing Shockwave like you do, Cindy, where we just have somebody come in and we do it once a month or once every 3 weeks, or sometimes every other week, because their body responds better to that. And that's usually after we've done like a series cadence every 6 months, every 3 months and then we're failing and having breakthrough clinical sign, then we'll try an ongoing. I have an LS dog with ongoing. He comes in every 4 weeks and he does best with that. We tend not to bring that up to owners first pass, but Deana obviously needs to know about that as an option if we're failing when we're doing our series, we're having that breakthrough. And overall, our technician being able to make the recommendation, legally, the prescription comes from the doctor. So I think, I wanted to just touch on that. So yes, I do make the official prescription for that, but sometimes Deana will come to me with a patient and say, hey, Rocco is having a bunch of elbow breakthrough pain. I think we need to do a series. And I'll say, awesome, I agree, let's do it. And so, at first I guided Deana, and we'll get into the details of training on the actual patients in the next slide here, but we sort of started with a little bit of an in-house protocol, and then she got really good at Shockwave, and so now she makes tweaks on the fly. And so that's why I say, like, I make that initial Shockwave plan and she makes adjustments to it in the heat of the appointment, and she's good enough to do that. And my goal was to get her good enough to do that, to be a decision maker in that patient's treatment plan. Okay, I lied. So we have one more. So what to expect. I think your tech needs to be able to communicate that. So we talked about the fact that the Shockwave benefit is often delayed, and so we want to just set owners up for that expectation so they're not disappointed that 2 days after their first Shockwave session in a series of 5 were not resolved. So we definitely talk about that on the front end so people aren't disappointed, and they know what to expect. And then we also describe just what a Shockwave session looks like, because some people still feel nervous after reading online. They could be loud and painful. We just sort of talk about dogs come in, they sit and they eat their snacks. It's all very low stress. And I put this picture. This is Foxy, and she's obviously having a pretty good time getting her. She loved her cervical Shockwave, so that's an actual treatment. That's actually not staged, but yeah, there she is. Okay, we're going to go into kind of the nitty gritty in a couple slides here, but I wanted to pause. You guys have any questions or comments on like kind of the outline of what we're trying to enable our tech with in terms of knowledge so far? Okay.
Sounds good to me.
Okay. We got to touch on safety. So like we do touch on like contraindications. I put open growth plates with an asterisk because Peaches had open growth plates and I shockwave the heck out of her. And so to me, this is a theoretical risk that hasn't been proven, that Shockwave will damage an open growth plate. And so when I'm making a decision, I just wanted to like mention this since I used her as a case example. When I'm like looking at a dog like Peaches, I weigh the pro and con. We have a theoretical risk that hasn't been proven, and then we have what I feel like I'm very confident in the benefit I'll get out of Shockwave. And so in Peaches' case, I felt like the benefit of the modality far outweighed the theoretical risk. And that was just my judgment. So that's why we moved forward and we didn't wait.
And I will add, according to the International Medical Shockwave Society I think it was 2023, they divided into high, medium, low energy, and you need high energy to affect growth plates. We don't have high energy, or we don't use high energy. So super safe. I agree. But
That's good to know.
always worth conversation with the owner. So.
Yep. Yep. And I've done that a bunch and I haven't seen any what appear to be negative effects secondary to that. Okay, so for the rest of this time, I wanted to talk about like specific Shockwave knowledge. Like, what do I need Deana to know in order to perform an excellent Shockwave session? And then the second part of this is like, she has to be able to palpate the dog's body for accuracy. Otherwise, she cannot deliver a good treatment. So this is like 2 different buckets here, okay? And so we're going to talk about like specific Shockwave knowledge. And I put the stifle up here as an example. And what I did for her is, for every body part that I felt like we were going to commonly treat, I came up with this. I don't want to use the word protocol. It's a jumping off point. It was a place for her to start. And so I picked I picked a body part, and I said, where are the areas of that we're going to focus on? So in the stifle, and this is like doctor dependent, right? And we use our judgment, and we have what we like to do. And so this is just like what I like to do. I work on the patella and the patellar tendon. I work on the medial dish. And I made that term up. It's just the dish to the medial aspect of the patellar tendon where you can really drop that focal point of your standoff pad. You can kind of drop it into that medial aspect of the stifle and really scan and fan in there and hit your cruciate and hit your medial meniscus. So I just called that the medial dish. So she and I had language. And then, of course, the medial joint line. Those are my 3 places I really like to work. And so when I taught Deana general palpation, we really focused on these 3 areas when we palpated the stifle. She has to know how to find these areas. So it kind of brought my teaching her palpation into focus when we got down to kind of the nitty gritty. I gave her a jumping off point for dose, and I say these are averages. And so you can see I have a hash mark. So I like to do the layered approach. I usually have one standoff pad that I feel like is a little bit more important, and that's where the higher number is. So you can see this will come out to 4,500 pulses over an average stifle, and we still do about this. There are exceptions. If we have something unique going on in the stifle, or if we have a dog who has low tolerance, we'll drop our pulsed number down. I gave her an average for the standoff pads I like to use, an average span of intensity, and then I like to, for every body part, we talk about the sweet spots, so where we tend to get biofeedback. And this is just kind of what I find, and that's also why you'll notice those correspond with my focal areas, our sweet spots. As Deana has gained a level of confidence and experience, I will layer on another kind of layer of detail for certain body parts. The stifle is a really nice example, because now if we have a dog that is a post-op TPLO, is a little bit different than an arthritis stifle, which is a little bit different than a acute meniscal injury stifle. We have a little bit of variation in those 3 in our practice. I didn't teach her that until she was very confident with what you see on the page. I just felt like it was too much. And not all body parts have those tweaks, but and I'm always tweaking things. I still do some Shockwave, so I still tweak stuff, and then I pass it to her. But I wouldn't have done that in the first 6 months she was working Shockwave. I just feel like that would have been overwhelming. I wanted to show kind of how we communicate with each other. So this is documentation. I can read and see, when a patient goes to her for Shockwave and then gets kicked back to me, I can see like what's actually been happening. So this is the piece of information I want to know. What session are we in our series? What number are we? What is our goal? So like I said, in the example, the stifle, our goals can be a little bit different. I like to know how deep into the series are we? Is this our first time? Is this our 10th time? We obviously have our body part and exactly what head we used, how many pulses, and what our intensity was. We talk about the areas scanned, which I can probably tell you that without reading what she writes, but sometimes we'll have a deviation for a reason. She'll say, gosh, on that iliopsoas, I was getting so much more feedback on the iliacus that I spent way more time there than up in the muscle belly psoas major. And so she might write that in there, that was like more emphasis there. I always like to know biofeedback. So where do they get discomfort? And then any other notes, anything that would be helpful if, let's say, I need to do Shockwave the next time for this patient. So this is kind of our outline for how we communicate with each other. Okay, it's my favorite part. Okay, should I pause? Any questions or comments, you guys? No? Okay.
No, it's the anatomy. It's all about the anatomy. Sorry.
Yeah. Okay, so yes, and I agree with Cindy wholeheartedly that your Shockwave treatment's only as good as the person operating it. And our PiezoWave is so focused and so accurate. And that is a double-edged sword, because if you are good at palpation, you are going to hit the spot and do an awesome job. If you are not good at palpation, it's pretty easy to miss the mark. And so I was very particular with palpation. And for Deana, I taught her not just palpation of the body parts we're going to be shockwaving, but she needs to know how to do a myofascial exam. She sees patients without me, so the dog comes in, she has to do a myofascial exam on every patient. That is baseline. And so that's where we started. And we started with the bones. Because a lot of our what I call home base palpation points are bony landmarks. So we took out our textbooks, we took out our skeletons, and we had live dogs. That's my dog in the photo. That's who we use most of the time because he's such a good boy. And we practiced palpating both in standing and side lying, and also partial side lying, all positions. And we went over, I just wrote out a list and I was like, okay, these are the bony landmarks that you have to know. Some are directly related to our shockwave treatments. Some are not. Some are more related to our myofascial exam. And we practiced over and over and over again until Deana felt pretty comfortable. And then we went on to soft tissues. And so we had a lot of like free time together that we did this work out of appointments. She also did shadow a lot of appointments so she could get the flavor of what does appointment feel like start to finish, but we'll come back to that. But this type of training was really one-on-one in the room after hours. And then we do some tune-ups on patients later after she had this baseline. It just took me a couple months to get her really good because this is not an easy skill. And so, yeah, we started with joints, bones, and bony landmarks. The joints, I didn't teach her a lot of special tests, but we did palpate all the joints, feel joint lines, feel range of motion, what is normal, what is abnormal. Then we moved on to myofascial palpation, spent even more time here. Like I said, with bony landmarks, we focused on the soft tissues that are important for shockwave, but there were some extra ones that were important for our myofascial exam. I did not teach her everything in the body. I felt like it would have taken me forever to like do that. And so I gave her what I thought was a thorough, like intermediate level skill set. So we're not a beginner where we can't find anything. I didn't teach her everything I knew. I guess that's what I'm saying. We would have gotten bogged down in the details. So I tried to find a happy medium where I was teaching her enough to be excellent, but not too much. And now, Deana's been with me 2 years. Now I can like layer it on and be like, hey, let me show you this thing. And that's really fun. And I can like add. Cindy and I were talking before you guys logged on, and I didn't put this in here, and I wish I had. But I teach an acupuncture certification course, and we teach palpation there too. And one of the things, and that's for doctors, and so one of the things I talk about there is when you like come in to touch a dog or any animal for that matter, coming in with a certain calmness and a certain energy about you will give you a lot of, you'll get more feedback and you'll get more rapport with that dog. And then you will get more feedback from them. And then you will do a better treatment for them. So every time we palpate a patient, it should be a rapport building experience. And so I taught her, like, you come into the room, you lay your hand on the dog, you take a deep breath in and out, and you bring awareness into your hands. And it's awkward and cumbersome at first, but it can happen in a moment once you practice. So I'm like, before you palpate, I need you to breathe, I need you to touch, and I need you to bring your brain into your hands. And every time we did palpation, we just like did that over and over and over. And it's really just attuning to your body and your patient's body so that you can get the information you need. So that is actually where we started. Then we started touching animals. I talked a lot to her, and we did a lot of coaching on pressure, speed of palpation, and interpreting pain management signals from your patient so that you don't need to make them cry out and that you don't need to lose rapport through your touch. So we talked a lot about having that style. that's how I want my patients to feel safe, and I'm sure all of you do too, right? And so we talked, that was like threaded throughout everything we did for palpation. Um, and what we did, I can't remember this next slide. Let's see. Yeah, we kind of talked about, where your patient is painful or weak. Um, I talked to Dean about like developing a pattern of palpation, and I showed her mine, but I'm not attached to how she does it. I just want her to find her way and do it her way. We talked about tissue texture, speed, and pressure. So I mentioned speed and pressure, and I did a lot of demoing for her, like good, bad, try it a good way, try it a bad way. How does the dog react? Um, and then also tissue texture. So at first we were working on my young Labrador, and his tissue texture is pretty healthy, which is a great place to start. And then as she would sit in with appointments with me and shadow, I would say, oh, come feel this. Come feel this top band. Come feel this trigger point. Come feel this fasciculation. And so then we would start feeling and seeing the abnormal. Um, if I had a subtle sign of pain in a dog on my palpation, I would point it out to her. Hey, did you see that? Did you see the look to the side? Did you see them step away? Those kind of subtle things that take a little practice to recognize. And these are kind of the general body parts that I wanted her to know. She knew cervical, both front limbs, all down the back, and hind limbs. So that's kind of in my brain. That's how I organize things, and that's how I taught her. That was kind of our order. Um, this was sort of the putting it all together, where we worked on this simultaneously because we would do this one-on-one kind of clinicking time where we didn't have clients with us and we were using my dog. And we'd actually recruit friends who would drop off dogs for us as well, so we could feel different dog bodies. And this was sort of the piece that Deana learned just sitting in on appointments with me. And I wanted her to just like hear how I communicated with patients. I wanted her to like steal words and verbiage that spoke to her about explaining things to clients. I wanted her to get like the general vibe, how we were professional and efficient, but we're calm and really kind, all wrapped up into one. And I think that the like calm and kind piece is challenging when you're first starting, because you're like so much in your brain. Oh, am I touching the right body part? Is this the right setting on the Shockwave? Like, how's the dog doing? And we get really like tight, and we second guess ourselves. And so we talked a lot about like, more than the client in the room. This stuff. Let's just be calm. And if you feel like you're off, or you feel like this is challenging, that happens to me too. I and I feel like I've done this long enough. I can talk about that openly in front of some clients and say like, oh yeah, I don't know where I am right here, but I'm in the right zip code. So like, let me show you what it's like to have a hard one. We all have hard ones. And we talked about the nitty gritty, right? Like being on time, because we see back to back stuff, and like, how do you structure your appointment so it feels really smooth and efficient, and you like walk away feeling like I did a really good job there. Um, Deana came from traditional GP, so we talked about how do you restrain a patient in a rehab environment, which is fear-free, volunteer restraining on their part, and all the little tricks to convince them that their therapy's awesome. And so we did talk a lot about that. And I mean, I demoed that a ton. So she like, stole all my tricks, which is great. We also talked about, Deana was very, and I think most techs who are able to get this training are very committed to doing a good job. So at the beginning, Deana had some nervousness about being by herself. And I said, here's when you come get me out of my room and interrupt my appointment. Here's when you like come talk to me afterwards and ask me questions. Here's when you tell your client, I don't know the answer to that. Let me ask Wendy, she'll get back to you. And so we like kind of had a little bit of framework for that. And now that happens organically. And that helps me have a lot of trust in her. And she seems to always kind of know where we are on that continuum. And there's been a few dogs that are really struggling in their appointment, and she'll come get me and be like, you need to put hands on this dog today before they leave. And I'm like, awesome, great. And so just having that conversation, I think, helped her feel like I had her back and she's not by herself. And it also helps me have confidence in her, right? That she's holding our patients and our care to a high standard. Um, that's it. that is it.
Amazing. Questions, comments? Anybody else working to train people? Does anybody have specific struggles? We have a quiet group. I have struggles. Are you going to come teach all of my sales reps how to palpate?
That would be really fun. Yeah, I'd do that.
I think that's my
I
hardest thing.
I have a good curriculum now that I did the acupuncture course, Cindy. So yeah, hit me up for that. I love teaching, so yeah, that'd be fun.
So, I think, we keep discussing on the business end for this modality, the benefit of it being technician trained, technician run, and done properly. Um, s- I think your communication skills with Deana are so important and hard to grow, right? And that takes effort to grow the great and the proper communication, and I can only encourage everybody out there to take the time to do it because the benefit in the long run is huge, right? Um,
Yeah.
it takes time and effort to train your help well, but the payoff is huge, right? And you guys are now talking the same language. And that's key to a working relationship in any business, even if it's whether it's rehab, sales, equine, anything. Like we all have to talk the same language as our colleagues to work best together. And it doesn't just happen from one phone call or one conversation or one meeting. So I I'm a, I love the fact that the time and the energy that you spent is you believe it's paying off, right? I mean, it's 2 years now and
Yeah. Oh yeah. It's yes, because I'm very particular, uh, and that I need to know that my patients are getting like outstanding care. And so if I don't feel like Dean is providing that, then I'm nervous to send to like let her see my patients alone, right? And so I just for me, my baseline is I need to feel confident that I can honestly say to my client who I've known for 2 years and deeply care about, you need to go see Deana for Shockwave. She's excellent. She will take really great care of you. I trust her. Please, see my colleague and you'll see for yourself that it's awesome. And all the clients love her. And so it just has to be super high quality. And I did take a ton of time. It took us 4 months. We did a lot of after hours stuff. And it's funny, like like I would teach her and then she would work on patients and I read all her medical records for a period. And I didn't want to make her feel like I was checking in on her, and I didn't want to give critical feedback, but I made myself do it because I was like, if I don't do it now and then I do it a year from now, that's going to be awkward, right? So I just got real comfortable tweaking her and saying like, "Hey, I appreciate all these things that you did here. This is what you did so well. There's one thing here I would change. Let's change that next time." And we were able to communicate in a way where that was like not personal
yep.
and I think that was it. I didn't just like teach all this information and go like, okay, let's see what happens. I did a whole bunch of follow up, and we do rounds every week. And that's been very, very helpful to stay on top of. Well, now we just do it to fill each other in, but before we had teaching rounds, and that's a lot of time when we taught.
No, I met Deana. She taught me a few tricks, few amazing tricks. And we're all always learning from each other. So
Mhm.
yeah. Any other questions from everybody in the audience? Um, I'm super excited to have this because again, we want this modality to be technician driven, but it's not just hand it over and run, and in that regards, time, energy, and effort gives you the big payoff in the long run. And we all know anything's only as good and valuable as those that run it and use it. So super excited to hear all of this and took notes to help my own team start learning more. It's on my 2025 list. So,
Yeah, and it's like very financially favorable to have your technician doing your Shockwave.
oh yes.
Yeah, it's like the way to go. I don't do Shockwave very much anymore. Um,
And on the flip side of it being financially good for the business, it gives us as technicians a place and kind of a feel for doing something really well, to be a champion at something, to enjoy it and to have value um, in something specific. So I think it's a good way to, keep your technicians engaged also and not
mhm.
have them bored and ready to walk out the door and some of those issues we have in general practice, right? So,
Yeah, I think that's the beauty of being a rehab tech is you get to be independent and you do a lot of doctoring. And I like to point out to Deana, there'll be times where she'll see a patient, like I'll do their initial, they'll go over to her for 5 Shockwave sessions. And by the time I see them again, they're so much better. And I always like to point that out to her. I'm like, you did that. I did nothing. You fixed that dog. And
yeah.
she loves that, right? I mean, I love that too, but
I love that part of being a technician, but being a rehab technician is a huge journey for
mhm.
sure. But so much to learn and do, and it's great people like Dr. Wendy who take the time to teach us. So I appreciate your time. If anybody has questions for Dr. Wendy, uh, please reach out. If you can't find her directly at Elevate in Colorado, I can connect you always, and she's a wonderful resource, not only for the PiezoWave, but for like running a standalone quality rehab. Okay. Thank you so much. Have a great night, and we'll catch up soon. Thanks, Doc.
Thank you. Thanks for coming, everybody.